So you
Good
guys
evening. I'm Dr. Max Gomez.
wait.
No,
Sorry. I haven't hit start webinar.
Oh, because it says recording. I'm sorry.
Yes, I'm just recording it and then I'll edit this part out later.
Okay. I got it. I'll start.
All right, so let's just get started in 5.
Good evening. I'm Dr. Max Gomez, a senior medical correspondent for CBS here in New York. And it is my pleasure once again to host a webinar here for Columbia and the New York-Presbyterian Stanley Children's Hospital. And tonight we have a really interesting topic because I know that as adults, we all are very anxious and nervous when it comes time to have surgery. Hopefully that doesn't happen very often, but it does happen. And the only time that anxiety, I think, is greater is when it's a child, your child, that's undergoing surgery. And that's what we're going to deal with tonight, is how to deal with that, what it means for anesthesia, for pain management, and so forth. And I think this is going to be a really interesting and very educational talk. Columbia, interestingly, is one of the few children's hospitals that have actually a perioperative services team. And we'll hear about that, but it includes everything from certified child life specialists, pediatric anesthesia specialists, pediatric pain management teams, the whole 9 yards. And we're going to hear from everyone. Tell us a little bit about that. And to introduce our panelists, let me introduce first the Surgeon-in-Chief at Morgan Stanley Children's Hospital, a dear old friend, Dr. Stylianos. Steve.
Thank you, Dr. Max. Well, it's a pleasure to be with all of you out there and with my esteemed colleagues who are my professional family. We're together every day and we give our very, very best efforts on behalf of the children that many of you send us or many of you bring to us. I would like to introduce everyone. I struggled on in which order to do so, so I'm going to take the easy way out and go alphabetically. First is Jessica Goldberg. Jessica is a certified child life therapist, and Jessica plays a pivotal role in reducing the stress of the morning and accompanying the children into the operating room. Next is SarahJane Guida, who is the Patient Care Director of Perioperative Services. Dr. Bill Schechter, professor at Columbia and the director of our pain management service. And last but certainly not least, Dr. Lena Sun, who is professor and vice chair of the Department of Anesthesiology and the director of Pediatric Anesthesia.
Great. Thank you, Steve. And before we get started, I want to make sure that everyone tuning in realizes or knows that we are, in fact, recording this entire webinar, and it will be posted later to our YouTube channel, the Children's, what was the official name of it? Oh, I lost it already. The Columbia Children's Health is how you search for it on YouTube, and that will be, you'll be able to look at all of the entire webinar. And also, if you have any questions for our panelists, go ahead and put it in the chat box at the bottom of your Zoom screen, and we'll try to get to that as we go along. Steve, let's start with you since you're the boss here, right? Let's talk about surgery here on children. I take it that it's not super common, but common enough that that we have a team working on this. Tell me about surgeries. Can they usually be done? Well, you mentioned earlier, how about outpatient versus inpatient? And then let's talk a little bit about anesthesia as well.
Sure. Well, we love for children to be with us the absolute shortest amount of time possible. The hospital is not the friendliest of environment, no matter how hard we try. And we want kids to be home and comfortable and feeling safe and nurtured. However, we bring them to the hospital, and I would say about 70% of our 10,000 cases a year 70% of those children are going to go home the same day, which is absolutely wonderful for them. Regardless of the acuity, it's something that seems pretty straightforward and simple to us may be the worst thing that's ever happened to a family. They could not imagine bringing their little child to the operating room. And the folks on the panel are the ones who ensure that that experience is the least frightening and the least stressful and the most effective possible. And I look forward to hearing my colleagues bring in their perspective on what we do to reduce that stress.
I guess what you do is to make sure everything in the operating room goes as well as it possibly can. And the rest of our panelists are the ones who are going to make sure that all the other stress factors are minimized, I guess. Is that a fair way to put it?
Oh, it's a definitely fair way to put it. And certainly if you talk to any surgeon, they're going to feel like they're the captain of the team, but we really are without hierarchy. Everybody plays a key role. And by the end of the hour, I think it'll become much more apparent how sincere I am about that statement.
SarahJane, let's go to you here for a moment as the director, patient care director of this big umbrella of perioperative services. Tell me a little bit about how do you prepare the child and the family for going into surgery? I mean, presumably they've gone to see Steve and he's gone through all the medical issues, but there's so much more to it. What do you do to start getting them prepared as much as possible?
Sure. So we have a team of about 20 nurses that do an incredible job to prepare the child even before they come into surgery. Each child is, of course, called ahead of time. And, you know, one of the pretty unique things about our department is we have a pretty robust pre-anesthesia testing, or PEDS APEX program, we call it. It's a pre-anesthesia program with 3 nurse practitioners who reach out to almost every single one of our patients prior to surgery. And we partner with these nurse practitioners to assure that, you know, for any patient that requires additional resources, maybe an additional call or a visit with Child Life, that we know that ahead of time. And, you know, one of the other pretty cool things I think we do in our department is we really believe in that idea of creating this atmosphere of feeling safe, that sense of healing. And Dr. Stylianos is right. It really has started with the partnership that we have with each other. You know, we meet together every day to discuss concerns, issues, anything from, you know, is it too loud in the space, to what's our case volume look like tomorrow? What type of patients do we have? But one of the biggest pieces that we've done this year is incorporated music into our space. And so I can talk more about that later, but it's really been incredibly instrumental in changing the entire atmosphere, preoperatively, but also postoperatively. Jessica will talk about the Vecta machine that we use. There's just so much that's being done, and a lot of these initiatives are led by our frontline caregivers in partnership with our anesthesiologists. But the music is pretty neat, and it's something that we've started this year that's really helped to take our care to sort of the next level.
Terrific. And I do want to, I want to come back to talk about that a little more in some more detail, but I did pick up what you said, that music was instrumental. I don't know if you meant that or not, but I thought that was kind of clever. Jessica, tell us about your area there, as long as SarahJane teed it up for you. Tell me about your part in all of this.
Yes, so my job sometimes starts even before the surgeries are scheduled, or right after they're scheduled, when the APEX team alerts me of a parent who mentions that they're having particular anxieties about the surgery, or their children have anxiety or questions about their upcoming surgery. They're not sure how to talk about surgery to their child, or even that their child has autism or some sort of sensory stimulation issues or any additional challenges that can add to the challenges that everybody else has coming into surgery. So when the APEX team reaches out to me, I will call the family, talk about all of these concerns, sometimes provide a preoperative tour for them to come into the hospital and see what they will see the day of surgery, the pre-op area, pictures of the operating room, where they will go for recovery after, and then even the inpatient units if they'll be staying overnight. And then if it's somebody that I'm not alerted of ahead of time, I meet them the morning of their surgery to go over any questions and concerns that they have, provide psychosocial support to the patients. And most importantly, in the pre-op environment, it's providing developmentally appropriate education and preparation to the child about what's happening. It's a very common misconception that parents don't want to tell their children about surgery because they think they'll be too scared or will increase anxiety. And so my job in pre-op is to give them the tools and the language to prepare their child so that they feel in control and have a job and a coping plan in place for when they go into the operating room.
And this isn't just for children with special needs, which you mentioned, but anyone that you've sort of been alerted to that seems like either the parents or the child are a little bit skittish about or very anxious about it?
Correct. And some days there isn't anyone that I'm particularly aware of. And so then I just meet as many patients as I can. So maybe it's their first time having surgery. Maybe they're what we call a frequent flyer who comes in very often. But my goal every day is to meet as many patients as possible so that they know what to expect. And then if they ever do have to come to the hospital again, whether that's for surgery or even just a doctor's appointment, they feel more prepared and less anxious about that.
And you mentioned, I think, pictures earlier. Do you show them pictures, or do you sometimes maybe bring them in and give them a little tour so that it seems a little more realistic than a picture?
Yes. So there's a lot of options. If they're coming from out of state, sometimes I do a virtual tour on FaceTime and walk them through the units. If they're able to, they can come in and see all of the units themselves. The only place we're not able to bring them into is the actual operating room. So that's what I have a picture of them for them to see.
Got it. Lena, let's talk an area that I think both adults and family and almost everybody I talk to, it seems that they're as afraid or as concerned about anesthesia as they are the procedure itself. Tell me about how you, as a specialist in pediatric anesthesia, what has been done to make anesthesia so much safer than it used to be? Because I think people still think that kids are little adults, but that's not the case, particularly when it comes to anesthesia.
That's absolutely true. I just want to also want to add that to what Jessica and what SarahJane has said, in terms of preparing the patients when it comes to sort of anxiety, not just overall the hospital, coming to the hospital, having surgery, but specific with anesthesia, when there are these families or parents or children that are being identified, we actually would have one of our anesthesiology faculty attending actually call the family and discuss this over the phone before they even come in, sort of in anticipation of some of the questions that I may have. In response to what you're asking in terms of what is it that's making it better than it used to be, I think it's like everything else. You get the right people to take care of the patients that you are taking care of. And we're very proud to be the group, the only group really in the tri-state area with board certified pediatric anesthesiologists. And, everyone is a board certified pediatric anesthesiologist and dedicated to practicing pediatric anesthesia full time. So these are really experts and and with a lot of experience. And so what is the best way to approach children. It's not just children, but when you take care of a child, you're actually taking care of at least three people. It's the child and the two parents, and so that's something that we're all mindful of. And obviously, we have more advanced drugs and techniques and devices, both for monitoring as well as for taking care of them. So when you come here, you're really coming to a place that we know how to take care of children, and because we've been doing it day in and day out.
You get a lot of questions about, well, do they really have to be general anesthesia? Can we somehow do it with local anesthesia? Which I guess might be tough with squirming children, but I imagine you get a lot of that kind of question.
Well, I think that that's still an area that we have not been able to successfully do in children, because when you think about adults that have what would be called, monitor anesthesia care or regional anesthesia, actually, it does require some degree of patient cooperation, and not all surgery are actually amenable to having that approach. And in children, the margin is much narrower than in adults. So we want to make sure that everything we do is with that in mind. So in that regard, general anesthesia is still what we do in most cases.
I guess part of the trick is convincing the parents that it's actually safer to do it that way than it would be dealing with local anesthesia with a squirming child. Bill, let's talk. This is not because you're last but not least. It's mainly because the rest of the panelists are a whole lot more attractive than you, me, and Steve, I think. But one of the things that I know adults certainly fear when it comes to surgery, and of course parents do when it comes to their children, is pain and pain management or control, and what you might use to accomplish that. Tell me a little bit about the pediatric pain program there, because I think it's probably as sophisticated as we'll find anywhere in the country.
Yeah, thank you. We are the first dedicated pediatric pain program in New York City. We started our program in 1995, 96, and that makes us a pioneer in the field. We have 6 members of our team, all of whom are board certified pediatric anesthesiologists who have special interest and expertise in pain management. We also have a number of anesthesiologists as part of our team who are experts in regional anesthesia, and they have pioneered the use of ultrasound so that the blocks that can be performed once the child is asleep can be performed safely and have a relatively high degree of success. We round on our patients on a daily basis, very often seeing the patients 2 or 3 times a day to make sure that they're as comfortable as they safely can be. And I think it's very important for parents to have realistic expectations in that regard. Our goal is to make someone 100% pain-free after surgery, but unfortunately, sometimes that's not possible. And so we strive to keep them as safe as possible by using various different techniques, not relying on one technique, with safety primarily in mind.
Mm-hmm. You mentioned regional pain block, and sadly, I've been the beneficiary or victim of that for shoulder surgeries. The goal there is lasting pain relief after the surgery, or what is that exactly for?
It can be a block that lasts for many hours after the surgery, sometimes as long as 6 or 12 hours. Occasionally, if the patient is staying in-house, we may place a catheter that bathes the nerve or nerve roots for several days, as long as 3 to 5 days after surgery. And sometimes that's all you need to provide complete analgesia. If a child is going home, the advantage of doing a regional technique is that they're comfortable when they come out of the operating room, and that gives us time to assess pain and administer either IV or oral medicine and get them nice and comfy for discharge.
Nice, nice. We're going to go back and talk about some of the medications that you'll use in a minute. But Steve, tell me a little bit about, this is something that I know I noticed changed in the many years that I've been covering this and that we've worked together. Parents being allowed to sort of accompany their child into the operating room and until they're asleep. Is that something that you guys allow?
But not only did we allow it, I think that Lena and her team pioneered this, really one of the first to go way out of their comfort zone and to acknowledge the fact that the separation event that can occur in the pre-op area can really derail the entire experience. So, yes, for decades, parents were mostly accompanying their children into the operating room. However, the revelation occurred, regrettably, it took a pandemic to show it to us, but during the pandemic, for various reasons, no parents were really allowed into the operating room unless they had the most unique behavioral issues that had to be dealt with. But what we found is that Jessica and her colleagues were absolute wonderful escorts into the operating room. What Jessica and her colleagues would do is establish a relationship with the children, playing, using tablets, all forms of play in front of the parents, and then being assigned to bring their children. I think it gave the parents a relief that they actually didn't have to dress up and go into a place where they were scared out of their minds. And the staff noticed it right away that the children were great, the parents were relieved, and the child life therapist, Jessica in particular, were just so much better at it. I think I should lateral it off to Lena too, to talk about the anesthesiologist perspective, but yeah, it's a new world now, and we learned a lot because we were forced to.
Exactly. And Lena, I do want to hear your take on that, but I have to say, Steve, that there have been a number of occasions where I've noticed that when the anesthesiologist or whomever offered the parents, do you want to come into the operating room with your child, said, oh no thanks, I'm way too freaked out by that. I don't want to have anything to do with that. But Lena, so what has been your experience, and what made you decide to go out of your comfort zone that way?
Well, that was, as Steve said, it was years ago. And that was sort of the beginning of understanding that there is this thing called separation and anxiety in children when you bring them into the OR. Mm-hmm. And that was, I guess, predates all of the wonderful things that child life people, for specialists, are able to offer. And over time, and there have been quite a number of studies that have been done. Yes, it does seem to help the children, but it also makes the parents very anxious. And sometimes they can't even, they have to mask it. And our experience has been that there are definitely children that can be helped having their parents come in, special needs children where parents know where specific coping plans. But by and large, because of this sort of pandemic forced change in our practice, we actually found a better way. And so right now, what we do is we try to make sure that the child life specialist, Jessica's team, engages the children, bring in those cases that are appropriate. There are also cases in which we actually have to give a child a pre-medication, which sort of allays the anxiety. And then there are certain children that, as have been alluded to, frequent flyers that sometimes parents are used to coming in, sort of hold the kids' hands, and those are appropriate. So it's now a much more targeted and more focused approach. And I think that we're just getting better at figuring out what's best for each child.
Jessica, what falls under child life when it comes to surgery here? Is it some, a few, most? not many of the children that you really sit down and try to allay their fears and anxiety?
I try to see most. Ideally, I would see every single child, because just having the opportunity for the parents to see them playing and interacting and not screaming and crying when they go into the operating room makes a complete difference. They see that they're coping well, they feel immediate relief. So even for a little baby, just a couple months old, I still try to go in with them with little shakers and put on their favorite music. And the little things like that can just help ease so much of the parental anxiety. Even sometimes teenagers, 17, 18, where a lot of times they would maybe slip through the cracks, they haven't had the opportunity to talk about their concerns, things they've seen on Grey's Anatomy or they've looked up themselves. It's so common that teenage patients do their own research and watch YouTube videos of their surgeries and have so many misconceptions. So there are some days that I do have specific patients that I know from ahead of time I've been alerted to, but more often than not, I'm surprised at how many patients I've thought, oh, this kid will probably be okay, where they sometimes need the most help.
Wow. Have you found, or how do you deal with the child who is refractory to child life intervention for their anxiety? I can't imagine that you're 100% successful.
Oh no, definitely not. There are some kids that will just be very upset, kicking, screaming, crying the whole time, and we just try our best. And one of the things that I learned in my training very early on is that sometimes from our perspective, it looks like the child's having a very hard time. But then when we come and talk to the parent afterward or the child afterward, they say, that's the best we've ever done. We're so excited. We're so proud. And so that's really helped to change my perspective on looking at these experiences, because it is scary and it's okay for a kid to cry and kick and scream going through this. So sometimes that happens, and sometimes kids don't want to talk about anything. They don't want to know the details, and that's fine too. I just go in with them, and we can just talk about their day and school and things they like. And if they don't want to do that, I'm there just in case something happens, and that's fine. I'm also the only thing in the hospital that they can say no to. So if they don't want to spend time with child life, that's fine. That's a choice that they are willing to make, and sometimes that's empowering.
Wow, no, good for you. So, Bill, let's talk about a topic that's been really in the news all over the place for some years now, and that's painkillers, opioid painkillers. To what extent do you use that with children, and how concerned are parents then as to what effect that might have on their child, i.e., or e.g. overdose or out and out addiction?
Yeah, it's very interesting because I've been practicing now for 39 years, and parents would just accept what we gave them. We would prescribe oxycodone, we'd prescribe methadone, and there was nary a peep. Now people are aware of the issues, and I must say that pediatricians and surgeons are also aware of the issues. It is undeniable that for some surgery, opioids are necessary, and they do form the backbone of our pain treatment regimen, but they're not the only drugs that we use. So we've taken a multimodal approach to pain management using drugs such as acetaminophen, which truly is a remarkable drug when used in combination with some of the other analgesics, nonsteroidal anti-inflammatory agents, local anesthetics, regional anesthesia, and opioids as necessary. It's very important to get a good history from the family. Some families have preconceived notions of the dangers of opioids. In some families, it's very real. There may be a history of opioid misuse in either the patient or the family. And so obtaining that history, doing that screening is very, very important. For outpatients, it's very important that we prescribe the right amount of medication and not dispense huge amounts of medication. Most kids only require a few doses for several days, and then Tylenol and nonsteroidals can usually take care of the bulk of pain management. And they also have to be instructed that opioids should not remain in the household after they're no longer used. So we provide some instruction as far as dispensing of the drugs and disposing of the drugs for families.
To what extent, though, has this concern about opioids in particular, has it led in some cases to under-treatment of pain, where the child is really still very uncomfortable because there's been this concern about the opioids?
I don't think so. We've taken this multimodal approach to pain management, and our practitioners are very, very careful about telling families that we don't really treat to a pain score. We treat to restoration of function. So we make sure that families understand that the reason we give opioids is to allow the child to take deep breaths, cough without pain, not guard because they have excessive pain, engage in physical therapy, get a good night's sleep so that they can do the things that they need to do to recover. And families do accept that. And a certain degree of caution we welcome, but they have to understand that pain can prevent recovery. So we try to be realistic.
Right. SarahJane, let's talk about an area I think I've always found really interesting, and it might even be more applicable to kids than it would be to adults, is the role of music in anxiety reduction, even recovery, but especially in easing the stress and anxiety associated with this. What have you found about music in kids?
Sure. So Jessica and I have been talking about the idea of incorporating music for years now, and we finally found a way to get it to perioperative services at Morgan Stanley Children's Hospital. And I think it started with the purchasing of our what's called our Vecta machine. This is a machine that is specifically for patients with sensory processing disorders. It's a pretty large machine that has tactile stimulation, music therapy, aromatherapy, and a whole bunch of sort of elements for these children to use to make them feel safe and comfortable during surgery, or really in any hospital setting. So hospitals really across the nation have this machine, use it for these cases. We found that we were starting to use this for all sorts of patients. And then we found that we were using it for staff, and we were realizing we were using it to develop this whole atmosphere that we've been wanting for so long. It sort of creates this really calming, safe approach and atmosphere for us. And so one of our frontline unit assistants took on the sort of project of working with the music therapists in-house to create a playlist specifically to perioperative services. And we happened at the same time to have been sponsoring with Disney, the Disney company. So across Morgan Stanley Children's, there are Disney murals and Disney windows for these patients. So our playlist has a Disney focus. But we play this music every day throughout most of the day, but it starts in the pre-op setting. So it has created, families love it and patients love it, but it's also created this really calm atmosphere for our surgeons, anesthesiologists, and nursing team. And it's sort of helped create, a more collaborative environment together. And Dr. Stylianos had said in the beginning that we're really a family where we collaborate together, and we're sort of function as a team of one. And it's very true, and you can really feel it when you come to the unit. And I believe that this music has really helped. I watch our patient experience scores very closely. And when you read the comments, it's unbelievable how the use of child life and the use of music and some of the really smaller elements that we've incorporated into patient experience, those are the elements that families take home with them. And so we really tried hard to make this experience more personal for our families. We've started to, as a leadership team, provide our cell phones to families that are particularly nervous, so that they feel they have direct contact to someone that could go into the room if possible. And of course, Jessica has been just instrumental, but the music has taken on sort of a world of its own, and our partnership with the music therapist at the Children's Hospital has really helped us to and just to take the perioperative experience to the next level.
But SarahJane, let me take you back a step here, because I spent pretty much most of my 40+ year career in academic medical centers. And I know the atmosphere in academic medical centers. And I suspect that you had to overcome a little bit of music is going to help this. This is, that's a hippy dippy granola crunching point of view that, show me something that really works. What did it take to overcome that and actually be able to implement it?
Well, I think that the relationship building has taken us years. And I think Dr. Sun and Dr. Stylianos will probably agree. It's this sort of, trust in one another and this sort of hippy dippy idea that we're one family. It really took a few years to build this. But I think we trust each other. And, when we started the first few days that we started putting music out there, I thought, oh man, what comments are we going to get from the surgeons, from, the anesthesia team? But it was just all positive. And when you look around, you see anesthesiologists singing to the songs, and it just creates this different feel that I don't know that you could do in the adult world, but we have it here, and we're so lucky that we do. And I really think maybe it was the pandemic that brought us a little bit closer together, a little bit more trusting of some of these more interesting ideas, but it's worked. And it truly, it's a nice atmosphere when you come onto the unit. And I think the families feel it.
Max, the other day, Myra really spiced things up by at 6:15 in the morning, she was playing Jazz Greats Do Disney. And it was disorienting, but it was so fun. And she had a little sparkle in her eye.
I've heard that disc actually.
Yes.
I've actually heard that.
Yes,
I love that.
That's what was playing at 6:15 in the morning. It was terrific.
Well, I don't know about 6:15 in the morning, but I have heard that. And Steve, I know that, your generation was more accepting of music in the, well, actually, ORs have always been a place for music. I guess the idea was, does it make a difference in the sort of preoperative atmosphere or situation? And as we always say, data talks, right? And when you see some results, that's what convinces everybody. Go ahead. You have something you were going to say?
I was going to say, anything that humanizes the experience, that takes it from a mysterious, frightening unknown that's probably very sterile, with a lot of people speaking in a language of medicine that's formidable, and anything that humanizes that experience is of tremendous value. And I think that almost everything that you've heard so far this evening is really that concept. We embrace that concept. We bring our own skill sets to it, but that's the concept that we embrace. We want to humanize this experience to a point where when that family goes home, they remember us for the right reasons.
Absolutely. Well said. Well said. Let me ask you one other thing. There's a question here that came in from apparently one of your colleagues. And I think it's actually on point. What role do you think the community pediatrician can have in preparing the child and the family for surgeon, preoperative clearance, how to communicate with the surgeon and the anesthesiologist, that sort of a thing?
Well, privacy things aside, I thank Jesse Hackle for that question, and he is a great pediatrician and a great friend. It's very insightful because what we need is to have the parents believe that they have brought their child to the right place, to the best place, that they were the best parents they could be by seeking out the best team. And if there's corroboration by their pediatrician, who they adore and trust and love, that's the most that they can do for us. The other term that I think of is age-appropriate honesty. I think that's a very, very important aspect of all medical care, and in particular, the operating room. Of course, you're going to speak to a 4-year-old differently than a 14-year-old, but they know what's going on. They sense it, they feel it, they see it, and to leave them out of it in conversation really doesn't do anyone any good. Now, I would say that there are certain terms that people could use that may make things worse, like telling a child they're going to be put to sleep, and they just, their pet was put to sleep a year earlier. Can that's not going to work. Or telling them that, oh, the boo-boo is going to get cut away. They don't want to hear the word cut. So there are terms, there's language. Jessica brought that up earlier, but age-appropriate honesty goes a long way.
That's interesting. And that's an interesting point too, that I hadn't heard before. That's really on point as well. Here's a question that let me put out probably to all of you, because I'm not sure, Bill, it falls partly, I think, under your purview and partly under Lena's here. For a long time, I know that it was thought that infants, babies, didn't experience pain. So we didn't really deal too much with pain relief in newborns and babies. And that has changed, obviously. This question is about circumcision. Why do you, in newborns, circumcision, use local anesthesia, but if it's done on older kids, you advise general anesthesia? Somebody take a shot at that.
Well, first of all, there's an abundance of evidence that during certain periods in neonatal life, intense painful stimuli or repetitive painful stimuli can modify the nervous system. We used to talk about contributing to the stress response, but it's not just the stress response. It is a change in the wiring and the functioning of nerves. And this is of tremendous concern, particularly for neonates who undergo a wide variety of procedures in the ICU, apart from any operative procedures, something as simple as a needle stick or an eye exam, for example. And these long-term changes that can occur in the nervous system can have an effect on behavior later in life and perception of pain later in life. And this has been shown in a number of studies done by some Canadian researchers, PhD nurses, and a number of British researchers as well as American. So ablating that pain response with local anesthetic has been shown to prevent that sort of change. Obviously, when you're doing a procedure as, shall we say, delicate or as associated with emotional impact as circumcision, certainly in an older child, you want to make sure that you've dealt with all aspects of pain. I like to tell people that pain is not just a sensation, it's a perception. And how you perceive of pain depends upon your genetics. It also depends upon your emotional state, how anxious you are. If you're very anxious, that will amp up the pain response. And it also is affected by your cognition, that is, your understanding of what the pain or the procedure represents. So it's very important that we not just treat pain with an ablative, with a chemical, but we approach it from all aspects. And that's what the child life people do. That's what Steve is talking about when he talks about language. That's what Jane talks about when she talks about music. I'm not sure that the music helps the children as much as it helps the adults in the room. I know that when I walk into the recovery room, first time I heard the music, I said, what's this? But now whenever I walk into the recovery room and I hear the music, it's relaxing. And it tamps down anxiety, stress, concerns of the day, and that can only be good for children.
Well, I think I just want to add that why we do local for circumcision in a newborn and you need general anesthesia for older child. I think it's exactly the point is that there is an age-related differences in terms of how you take care of children for even the same thing. So a circumcision in a newborn is very, very different than circumcision in a 10-month-old or even 2-year-old, because it's a very physiologically different child, and also because it's more than just managing that painful sensation. There are a lot of psychosocial factors and all of those things are involved. So, and then obviously, then you can ask, why don't we give general anesthesia to newborns for circumcision? The reason is because it's like everything else is risk and benefit involved, and giving general anesthesia in newborn is probably more risky than giving it to anybody else. So it could be done under local anesthesia, and more normally obstetricians or rabbis will do that, actually do that very well. So no, we don't want to give general anesthesia newborn for circumcisions, and we certainly cannot do local anesthesia for circumcision in older children.
Let me ask you something that's a little bit related and something that I know parents sometimes are concerned about. Are there long-lasting effects to anesthesia, particularly general anesthesia, that they should worry about, watch out for, or do something about to ameliorate it?
Well, well, first of all, I'm wearing this pin. It's a panda, because we actually did a study that's named Panda, and that's a study actually exactly trying to address that question. So we actually did a study in sibling pairs, one child who had anesthesia for hernia repair and the sibling who did not prior to 3 years of age. And we looked at them, when they're between 8 to 15 years of age, and the siblings are very exactly the same in terms of their IQ, in terms of everything that we can look at using a neuropsychological testing. So the answer is that if it's a healthy child coming for elective procedures such as inguinal hernia, we have not found that there should be any long-lasting effects. On the other hand, you should always try to try to practice best medicine. You should not do an relatively elective procedure that can be done in an older child that you don't have to do in a younger child, because as I mentioned before, the risk is always higher in children. The younger they are, the higher the risk it is. So the long answer to the answer to your question is that parents should feel rest assured if they're having a child that's coming in for general anesthesia, the child who's relatively healthy, you don't have to worry about there should be any long-lasting effects. Obviously, it's very different for anyone who has other medical conditions and other issues that are related, because we don't really have the answer to that.
Okay, that's fair. That's fair. Steve, how do you take out stitches in a squirming child?
Well, the best answer for that is we don't have stitches that have to be removed, because chasing those little ones through around the exam room and through my office would be the worst ordeal for them. So we really embrace techniques where there are no external sutures.
Fair enough.
Yeah.
Dodge the question, but okay, thank you.
No, but that's the honest answer.
True. I always like, and because we have 5 panelists, and I see that we're nearing our hour together here, I always like to ask our panelists for a take-home message, a little pearl of wisdom. We obviously we haven't covered everything here, and it can be something that we haven't even covered, but give our viewers something that you want them to remember from this webinar, a little pearl of wisdom, as it were. And let's see, I'll go probably more or less left to right on my screen here, which means, Jessica, you're the leadoff batter.
All right. So I would like to reiterate what Dr. Stylianos said about honesty, child appropriate honesty. I think that is huge and something that has been changing a lot in the medical field, but children are so much more aware of what's going on, and the unknown is oftentimes a lot scarier than what's actually happening. So it can be scary to think about being honest with your child about anything medical that's coming up, but it is very, very important to not keep that a secret so that they feel prepared and in control.
Yeah, the unknown is often much scarier than the reality, right?
Yeah.
Lena, why don't we let me skip over and jump to you, please. What do you want people to remember in particular about anesthesia?
I think what I want to say is that, we are a group of physicians and practitioners that feel that we are both practicing art and science when we give anesthesia to children. And when I tell parents, when I speak to them and discuss anesthesia, when I would say, if this were my child, this is what I would do. And that truly is how we approach it.
And if I may, before we go on to the rest of our panelists, because we've got a couple of extra minutes here, it looks like, let me ask you a question, because I've often wondered some of this myself. Why do you ask a child to fast before anesthesia? How long does it need to be? Liquids, solids? What about taking medications? Can you do that in 1 minute for me?
All right, I'll try to do it quickly. The reason we want adults and children to fast is because there is a risk that if you do not have empty stomach, you can come up and get into your lungs and you can get into all kinds of problems. And those are solids. On the other hand, it's very, very different when it's just clear liquids. What we mean by clear liquids is if you can see through it, it's clear liquids. And we actually would like to encourage children to have clear liquids up to 2 hours prior to coming to the OR. In fact, there are new data that suggests that it could be 1 hour. They can have clear fluids up to 1 hour prior. We haven't changed our practice yet. We're looking at that. But we don't want children to have solids, but we would like to encourage them to take actually clear fluids. And medications, mostly if, this is something that is actually individualized. It depends on what the medications are. And that's what our wonderful Apex team will speak to the surgeons and the family about whether or not they should be able to take their medications with a sip of water or something.
Good. Thank you for that. Thank you. SarahJane, what about child life do you want our folks to remember?
I'd say in terms of pain management that, think about those non-pharmacologic environmental changes that you could make to your environment that could help both the patients and their families. Obviously music, but light modification. And then the last piece I'd like to, the listeners to take away is just to build that relationship with your team, your partners, your leadership team, but also the frontline team that sees it from a completely different angle. Oftentimes, those are the ones that have given us the ideas, and they've been the agents for the change. And so listening to those frontline teammates is really, really important.
Listening is important. Bill, this is your area, is one area that I think so many parents are really concerned about. What do you want them to remember?
We will partner with them. And we, just as we partner with each other, and I mean the nurses that are on the floors in the ICUs, we have an extraordinarily dedicated nurse practitioner who provides the glue that keeps the service functioning at an extraordinarily high level, and ensures continuity of care and communication between services. And that's so important to keep people on the same page, to understand what the needs are, and we'll do the best we can. You know, treating pain is quite difficult. Sometimes it's imperfect, but parents need to know that we certainly make the effort, and we succeed 99.99% of the time in doing what's right for the patient and what's safe for the patient.
Yeah, fair enough. Thank you. Thank you for that. Steve, as the chief, you get the last word. But before we get to your pearl of wisdom, I have a question here that just came in, because we've got an extra minute or two, which I have to say has never happened in these webinars. We have somewhat long-winded people on some of the webinars. Do you try to schedule patients by age at all? Younger patients first, followed by older? Does that make any difference? Does that make any difference as far as the rest of the team goes?
Well, it does. I'm sure the others want to answer also, but the answer is absolutely yes. And it's simply for several reasons. One is the amount of time without fluids. So we give priority to the babies so that they can have a clearer, distinct time when their last feeding can be. And also that the older children can tolerate waiting a little bit better. They can watch TV, they can put their buds in their ears and listen to podcasts, whereas the little ones, they let you know that they're not happy about the service if they're not in the OR. So we definitely do it by age. Very good. So what's the pearl of wisdom that you would like people to take home from our webinar tonight? Good. Well, and Max, thank you for facilitating this conversation. It's as usual, it was brilliantly orchestrated, and we appreciate it very, very much. My pleasure. I would say that whether you're a pediatrician or a parent, I would urge you to choose your perioperative team wisely. And what I mean by that is that the skill sets required, both medical, technical, and psychosocial and emotional, those skill sets are not easy to find like for adults. They're not everywhere. They're not down the street at the local hospital. And sometimes you have to abandon convenience to find that right team, that team that's going to humanize that experience, a team that's going to show you confidence in their recommendations because they're familiar with what your child has and they've taken care of hundreds of children with those conditions. It's going to feel different, and that really matters a lot. So choose wisely. Boy, I couldn't have said that better. I try to talk people into believing that all the time when they come to me and say, where do I go for this particular condition? And it's so important to not just have the right surgeons such as yourself, but that whole perioperative team. Absolutely. Will make just a world of difference. I want to thank all of our panelists tonight. This has been a really interesting and educational webinar for me, and I hope for everyone who will be watching and listening going forward. Just remember, it's on, I lost it again, it's on YouTube. Children's, why am I so disorganized here?
Columbia Children's Health.
Thank you. You should see my desk. You'll know why I can't find the darn thing. Anyway, on the YouTube channel, you'll get a chance to go over it and listen to it, and perhaps even pass it along to your patients or other colleagues who could benefit from it. Again, thank you so much for joining us tonight, and we'll see you next time. Good night.
Thank you very
Thank
much.
you, Max.
Yep, you bet.